this month is going to be from the department of the endocrinology as well as newborn department. The first talk is going to be from Dr. Suja Mariam on when every drop counts, Mother's Milk Bank giving hopes to mothers and babies in NICUs. Over to Suja.
Very good morning to one and all. It's a very bright Saturday morning, and I'm glad to be kickstarting this month's clinical meet. So, a small disclaimer, I'm not going to present any clinical case, but I'm trying to give a small insight in what our Mother's Milk Bank is doing for those who are not aware of it. So, it is going to be more like a seminar, but I'll make it as interesting as possible. So when every drop counts, Mother's Milk Bank giving hopes to mothers and babies in our NICU and NICU across the city. So we have established a completely automated Mother's Milk Bank at our Sri Ramakrishna Hospital. It is in basement 1 of the new block. It was established in the year of August 2021. We have state-of-the-art technology with automated pasteurizers, deep freezers and microbiology backup. So far, till this year, we have collected 1.2 ml of mother's milk as of October 2024, and we are going to celebrate it too soon. Many people always question us, starting from gynecologists to pediatricians to parents to other physicians, on is it pasteurized human milk is as beneficial as mother's own milk? Is it necessary? Should we place so much insistence on the use of or the establishment of mother's milk bank? Is it just a new fantasy that mothers are carrying on, that I'm giving only mother's milk, or is it actually scientifically evidence-based? So I just want to give a small insight into the science behind the use of pasteurized human milk and human milk banking. Now in our NICU, this is our 2023 statistics. So we have total inborns of around 1,104. We also, of which we have 550 NICU admissions. So 30% are from inborn neonates, around 360. We also have a bunch of inborn neonates who are not in NICU but are high risk. They are underweight, they are late preterms, they have feeding issues, they have high jaundice, and they keep moving in and out of NICUs. We have around 150 outborn neonates who are separated from their mothers during the period of sickness and stay with us for an average of 3 to 5 days. So based on the statistics and also on the evidence available, that for a high-risk mother who is delivering preterm or when the mother and baby is separated, the average time when a mother can produce adequate amount of her own milk is about 7 days. So it is this crucial 7 days when the baby stays with us. So from this, we were able to predict, and it matched with the data also, that almost 500 neonates in our hospital alone get benefited from pasteurized human donor milk every year. It doesn't mean that these babies don't get their mother's milk. Yes, they get their mother's own milk, but to top up or to meet the insufficiency during the crucial period of the first 7 days, they get the benefit of pasteurized human donor milk. When people started establishing NICUs, when we neonatologists started dropping up, we started looking into the reasons for death in NICUs. We wanted to show outcomes, good outcomes. So we wanted to see why babies were dying. Neonatal deaths in the NICU can be classified as early deaths, like in the first 7 days, which happens because of respiratory distress syndrome, pulmonary hemorrhage, intraventricular hemorrhage, early onset sepsis. We have prevented almost all of this deaths because of good antenatal care, good obstetric backup, where we have adequate antenatal steroids. We try to prolong pregnancy, early management of PIH, early management of fetal growth restrictions. With that, we have been able to, like so far in last 1 year, we have not lost a baby in the first 7 days. Late onset neonatal death happens because of 3 conditions mainly: sepsis, necrotizing enterocolitis, and bronchopulmonary dysplasias. When NICU started fighting over the early death, they started focusing on the causes of late death. They tried multiple interventions like using probiotics, preventing sepsis, limiting use of antibiotics, gentle ventilation, CPAP, everything. But finally, the one thing that improved the outcomes of this neonate was human milk. So it became a norm in neonatology perspective that human milk is a life-saving drug. It is the best food for preterm infant, and it should be a main component of premature infant care. That if you have a good NICU, you should have promote breastfeeding, and you should see that all your babies are exclusively being fed human milk alone. Now, how human milk helps? This is a little bit into the science. So, this is a term neonates a gut epithelium immediately after delivery, and this is a preterm neonates gut epithelium. In a term neonates epithelia, there is a rampant amount of stem cells which is proliferating. There is a thick mucosal layer which is abundant with antimicrobial peptides. The enterocyte tight junctions are actually functioning well, and there is a lot of lymphocyte, mucous tissue associated lymphocytes. The baby is usually born by normal vaginal delivery. The mother is usually risk not receiving any antibiotics. Once the baby is born, because of the vaginal flora, the baby gets colonized with facultative anaerobes and aerobes, which are the beneficial bacteria. The baby is started on early breastfeeding. There is no NICU stay, no OG tube, no suctioning, no endotracheal tube, no devices. So there will be beneficial bacteria which is in predominance. The baby goes from early, and other factors that can be affected will be avoiding pre-lacteals, avoiding formula feeding, avoiding post-natal antibiotics. Depending on all this, the baby's gut epithelium develops. Whereas when a preterm neonate is born, these babies, the tight junctions are actually highly permeable. They have a very patchy mucous layer and almost absence of antimicrobial peptides. There are very few Pennant cells and mucosa associated lymphoid tissue. So they have all devices in place. They have IV lines, they have umbilical venous catheters. The first thing we do when they are born is we put a suction catheter in their mouth. They are not getting any contact with their mother. Most of them, the deliveries are high risk. The mother is on antibiotic, the mother is on steroids, and the babies get delivered by emergency LSCS. So they don't get the benefit of the vaginal flora. So they get colonized predominantly by pathogenic bacteria like Staphylococcus. This Staphylococcus, these pathogenic bacteria, they start causing inflammation in the mucosa. They go into the mucosa and they permeate the mucosa and cause inflammatory cascade. So there is already reperfusion injury which is happening. In addition, there is inflammation which is caused by this bacteria. And we have now realized that the inflammation, it is all gut feeling. Everything starts from the gut for a preterm neonate. Earlier we used to think that sepsis used to start because of invasive devices. Now we know that the gut bacterial microflora changes and it permeates into the circulation, and most of the sepsis happens because of this change in gut microflora. It is related to the survival, feeding intolerance, like we have still in our NICUs lot of babies who have gastroesophageal reflux, they have constipation, bowel immotility syndromes. The change in gastric microflora change leads to all this. Necrotizing enterocolitis, which is a life-threatening condition where once it has happened, the mortality is as high as 50%. It is related to retinopathy of prematurity and hearing losses. It is related to bronchopulmonary dysplasia, and even when the neonates grow up, it is directly related to allergic diseases in them. So if you want to prevent all this, they have realized that we have to protect the gut microflora. So we saw that mother's milk is actually protecting the gut microflora, but do pasteurized human donor milk exert the same effects as mother's own milk? We all accept that breastfeeding is beneficial, but are human milk bags necessary? After pasteurization, do they carry the same benefits as mother's own milk and as direct breastfeeding? Is it so beneficial than special infant formulas? There was a parent who came to collect PHDM from a milk bank, and after collecting, she sat and discussed with me, there are so many formulas available. Why am I made to come and collect PHDM from this milk bank? Why can't I give formula? It is so much cheaper. I can have it in for a week or so. So why are they forcing that I should give PHDM to my baby? Now, in the earlier part of the years, when milk banks started cropping up, this is evidenced by systematic reviews and RCTs. We have found out pasteurized human donor milk significantly decreases incidence of necrotizing enterocolitis. So as I said, this is one of the leading causes after sepsis. The leading cause of death in NICUs is necrotizing enterocolitis. It improved feeding intolerances. This reflex, infantile colic, everything is decreased when pasteurized human donor milk is used when mother's own milk is not available. Shorter time to full feeds. So if mother's milk is not available, when a 1 kg baby comes to NICU, we put them on IV fluids and total parenteral nutrition. 10 years back when you used to study, they say that you start feeds only after 7 days. One mother's own milk is available. Till then the baby will be on TPN. And then we start feed, it will take at least 15 days for the babies to achieve full enteral nutrition and stop IV fluids. Nowadays we start feeds as early as 24 hours and sometimes even as early as 12 hours. Baby is stable, we start them on enteral feeds and by 5 to 7 days they are on full enteral nutrition. And then the only phase that happens is when we start promoting breastfeeding and prepare them to go home. As a reflection of this time to achieve full feeds, they have shorter duration of hospital stay also. One problem was that when compared to infant formulas, when we are giving pasteurized human donor milk, the weight gain rate was slightly slow in the initial periods. But when we look into the long term, these babies achieve breastfeeding earlier than the babies who are fed on formula, and therefore the long term growth, like 1 year, 2 year growth, is not different between babies who are receiving PHDM and formula. I'm not comparing them with mother's own milk. Mother's own milk is always superior, but only in its absence we are discussing the benefits of PHDM when compared to infant formula. There were some evidences which were talking against pasteurized human milk. The milk banking process. I'll show pictures of how the milk is handled. Pasteurization, repeated freeze thawing, storage, and partly inactivates the biological substances. The one thing that we talk in breast milk, immunoglobulins. See, secreting immunoglobulin A found in donor milk, it is not very well tailored to the infant's needs. For example, mother's milk is tailored to her baby's needs. If a mother has a particular infection, she produces the secretory IgA against that infection and it protects her baby from acquiring that infection. But when we are giving donor milk, it's a totally different mother. Her immunoglobulin profile will be different, her infection profile will be different, and whether that immunoglobulin will be protective for the baby that we are giving is actually doubtful. Risk of vertical transmission of infection. So this is one query that comes to all parents' mind. HIV, hepatitis B, what if the mother is on having some viral infection and baby gets that infection? We have been able to control most of the viral transmissions by using pasteurization technique, but still we have to fine tune it. And one another concern is infants who are fed donor milk showed slower growth rates in comparison to infants who are fed preterm formula. So in NICU, if there are two babies, one on formula and one on the donor milk, this donor milk baby will be gaining only 18 grams, 19 grams per day, and the other baby will be daily happily 25 grams, 30 grams per day. So the mother herself will start comparing. Can I also go to infant formula for my own baby? So this is a short glimpse. This is actually a poster we use in Mother's Milk Bank. The milk is handled plenty of times. But to give you a short awareness, once a mother, like if your relative or anybody wants to donate her breast milk, if she's feeding her baby and she wants to donate her milk, she is actually screened. So we take a short questionnaire from her, we collect all her antenatal reports, her HIV, hepatitis B screening reports and all. Then we allow, in our milk bank, we are allowing home collection. She can pump the milk, she can freeze the milk in her own freezer itself. So we have somebody called as Nectar Bees who are volunteers from Rotary and our hospital who go door to door and collect the milk in our vacuum carriers and bring it to our milk bank. In our milk bank, the milk is stored in a deep freezer. They are not immediately processed. The average time to process them after collection is around 1 to 2 weeks. So once an adequate amount of milk is collected from a mother or two mothers, the milk is actually pooled. It is mixed together because she will be collecting 100 ml one day, 200 ml one day. So we pour them in a common container, we pool them and then we pasteurize them. We give numbers to each and every bottle which we are pasteurizing. And from a batch, we send only one sample or bottle sample for culture. So if that sample comes as sterile, we presume that the other bottles are also sterile, that the pasteurization process is complete and the pooled sample is actually sterile, and therefore we start dispatching the bottles once we get the culture report. So the milk is stored at minus 20 degrees Celsius. We have an expiry date for about 3 months from the date of pasteurization. So this is how the mother stores the milk in the freezer. This is how we store it. Once the unpasteurized milk comes, we store it. We thought like this is from a single mother. We have collected around 10 bags from her. We thought we melt it. We pool it in the laminar flow and we pasteurize this. This is an automated pasteurization. And once pasteurized, we store them in sealed bottles with barcoding and unique number for each bottle. So for each bottle, we know who was a mother who donated and when was it pasteurized, what was the culture report and all. Everything depends. Who are the mothers are donating, what is their diet, what drugs they are taking, at what time of their delivery they are expressing, whether it's in the first day or whether it is 3 months after the delivery, how the milk is handled, how their staff is handling the milk, after how many days are we pulling the milk, immediately after 1 day after collecting are we pasteurizing it, or after 2 weeks we are pasteurizing it, and what is the pasteurization process and how it is affecting the nutrients. So mother's own milk, which is so precious, undergoes so many changes when it enters a milk bag and when it is pasteurized. So these are the technical details. So let's compare a preterm milk, and these are two different data. This was the initial data which came about of donor human milk. This is the recent data. We can find that there is a fall in the protein content, and fat content varies, depends upon the method of pasteurization, and the energy calories also decreases significantly when we are pasteurizing milk. A preterm milk, mother's own milk, fresh milk has 77 kilocalories, whereas when you are pasteurizing it, it falls to around 50 kilocalories. We also tested our pasteurized human milk recently as a part of a PhD thesis, and we found that it is only 55 kilocalories per 100 ml when we are pasteurizing it. Most importantly, the immunonutrients, lactoferrin, lysosine, lactalbumin, secretory immunoglobulins, everything falls when we are doing pasteurization. Recently, they have started studying the high temperature, short time method of pasteurization. We are using the classical Holder's pasteurization. With the newer technique, most of the immunoglobulins like lactoferrin and secretory immunoglobulin IgA was preserved when they are using this newer flash method of pasteurization. We don't have flash method of pasteurization. Another type of studies that they did in these babies is they fed the babies with pasteurized human donor milk and they collected a stool for microbiome. Whether the flora in the stools was matching mother's own milk or it was closer to the formula fed babies. This actually changed their perspective. This is actually the only study which is supporting or which makes people use pasteurized human donor milk rather than infant formula. The flora was almost very similar to babies who are on mother's own milk. So we can still believe that the gut microbiome is similar, is protected by using donor human milk. When a baby is on formula feeding, there is abundance of streptococcus and staphylococcus, whereas a baby is on mother's own milk or donor human milk, there is abundance of Enterobacteriaceae and lactobacillus. The long-term neurodevelopmental outcomes, it was actually matching with the pasteurized human donor milk and neonates receiving mother's own milk. And we found that when compared to infant formula feeding, when they grow up by 17 years of age, they had lesser levels of C-reactive protein and LDL-HDL levels were in a favorable range when babies in the neonatal period received pasteurized human donor milk rather than infant formula feeding. So all systematic data reviews till date 2021, they are favoring the use of PHDM in NICUs for high-risk neonates when mother's own milk is not available. So this is our mother's milk bank. It is in basement 1 near to the ultrasound room. So we have a 3-roomed chamber where we have separate reception, mother's milk collection area, processing area and storage area. So far with our milk bank, we have been able to collect almost 1.2 million. So the collection volume is actually increasing year by year. And our discarding rate, we discard when the mother milk is physically denatured or when our culture comes out positive, is actually very, very low. Around less than 1% of the milk alone we are discarding after collection. And our culture positive rates after pasteurization is also very, very low. 0.5 to 0.7% is the culture positive rates after pasteurization. That means even after pasteurization, the bacteria are retained and we have to discard the milk. So as mentioned, we have collected around 1.2 million milk, less than 1% wastage and less than 0.5% of culture positivity. We have been able to achieve early initiations of feed, that is within 24 hours in more than 80% of our NICU neonates and within 48 hours in 95% of the NICU neonates. Exclusive human milk feeding during NICU stay in more than 90% of NICU neonates. Of course, human milk banking goes hand in hand with breastfeeding support. So we encourage mothers that you have to keep expressing your milk, keep meeting your baby, allow your baby to suck even if you are separated, and we try to make them provide milk when the baby leaves home. And we are proud to say that many of the mothers whose babies were on pasteurized human milk, They become donors when they reach home and they are able to produce adequate amount of mother's own milk. We are currently providing PHDM to babies who are less than 34 weeks and less than 2 kg week. Unless a parent denies to give consent, PHDM is the norm. More than 34 weeks, there are some motivated parents who come and ask for donor milk, and we provided to those babies also. We have peripheral ATMs, anytime mother's milk, in 2 hospitals and in our Pachapalayam center, where PHDM will be available in deep freezers. So any baby who is requiring in that area need not come to our hospital. They can collect milk from that area itself. Through ATMs and main units, we are providing PHDM to 10 hospitals in Coimbatore, and there are 2 Chennai hospitals who are receiving it from us on a regular basis. What we need to develop in future, I would say that we are still in a premature state. We need to develop our techniques slowly as evidence starts building up. One thing is automation, where human handling and human errors can be decreased in this pasteurization process and pooling process. Milk analyzer will be beneficial because we can see whether actually we are able to improve the quality of the milk in terms of protein and immunoglobulin content. And we have to go to the modern methods of pasteurization as equipment start coming in, so that the immunoglobulin profile of the milk can be retained. Thank you. Yes, sir.
The neonatology is closely linked with obstetrics and gynecology with preference. Yes, you can.
It is about 1.2 million ml is about a little over 3 liters a day. Who are the donors actually? How are they motivated? Are we? Is it charged? If yes, then what's the?
No, we are not paying the donors and we are not charging the babies also. Donors, there are now lot of mother's health groups. We also have mother's health group in our hospital. So we create awareness that you have excess milk, please keep donating. We have posters all over, and we are tied up with 2 of these parent support groups. Coimbatore Parenting Network, they are a big Facebook group with 2 lakh members. And we also have this Achindya group, which is a mother antenatal classes are going on. So through them, we are contacting parents, and there is a lot of awareness among the Coimbatore parents nowadays regarding mother's milk donation. So when they have excess milk, they contact us. We have a helpline, toll-free helpline number. They call and if they wish to donate, then they explain them the process.
More quick question. I saw one slide that's translated into benefits with the mean blood pressure and diastolic blood pressure. But at what age group were they assessed?
17 years. 17 years. That was a single study with 126 neonates. And the BP and CRP levels, they were done at 17 years of age.
By the numbers, it's not a strong data, but there's some inclination.
Because milk bank started coming up in 2004 only. So long term, 30-40 years, we don't have still.
That's fantastic. Thank you.
Madam.
It's an excellent presentation. Congratulations to Suja and the team, and we are happy that we are the pioneer in the city as well. And as you said, it has been made aware to many people. Even the one person who has been donating for a long time, she was actually honored in our conference in the annual meeting, and that goes with every gynecologist that it is there. And she also talked about what we have in our institution. So the awareness has to be made more and more to every other person, including the mothers and the visitors in the hospital. So that will be a good input for the milk.
Yes.
Please, all the best for the future. Thank you.
Suja, I have a few questions. In the statistics which you have shown, there is 50% admissions in an ICU.
Yes, sir.
One, I want
30% admission in our NICU.
Because the numbers were the per annum, were something around 1,000 plus. I said around 500 plus in ICU.
360 were inborn. So inborn neonates were 360. So we had
others are from outside.
Outside.
Outbound
150 were from outbound neonates.
I was just curious to know what led to NICU admission, because 1 out of the 2 getting admitted in NICU.
We have very restricted NICU admissions, sir. Like not all over babies come to NICU, but still we are a very high risk center. So lot of we had 70 twins and 30 triplets, 20 triplets last year. So all of them will be underweight and they land up in NICU.
The question remains pertinent to the mother's this donor milk is the allergic diseases later on, because I'm sure there is no long-term data on that,
Yes.
to the infections, which are very dormant.
Yes.
So what's your comment on that?
So one thing is whether pasteurized human milk
Because,
prevents infection.
Because as pediatricians or as we have listened to our teachers, the best way to prevent allergic diseases in newborn or children is to have a breastfeeding.
Yes.
Breastfeeding. So what happens to, because there is significant change in the lactoferrin lysozyme and the soluble IgA, which is very important for the sensitization of our immune system to prevent the allergic cascade to develop in that particular individual. What happens to these babies who are fed with pasteurized milk?
Okay. Somehow the clinical data so far is that pasteurized human donor milk has prevented infections in NICU when compared to units which are formula feeding and which units which are using PHDM. The infection rate in NICUs is less with PHDM, but we are not been able to pinpoint why it is happening. Even in our milk bank, we did a study like the antibacterial activity. We plated different bacteria in plates and we poured in the PHDM and compared with mother's own milk. We were finding that the antibacterial activity is less with PHDM. But probably because of the FOS and BOS, the prebiotics which is present in the mother's milk, somehow the overall in the final clinical data, the infection rate is less when we are using PHDM in units when compared to infant formula. And the second thing they were contributing is because of the gut theory. So if you are using infant formula, there is going to be damage to the mucosal epithelium, and so the bacteria will translocate from the gut and cause infection rather than milk itself protecting from infection.
Because there is an interplay between the mucosa of the nose, respiratory as well as the gut.
Yes.
So that gets blocked or gets changed when you feed with this milk. Yeah. Now I want to know your comment on when you give this pasteurized milk.
Yeah, pasteurized milk, as I said, clinically as per data, it decreases infection. It decreases the inflammation in the mucosal tract of the respiratory epithelium also. The one best outcome was it decreases BPD rates when we are using PHDM in the absence of mother's own milk. So when mother's milk is available, they will be giving it. But instead of formula, they will top up with PHDM. So BPD respiratory infections are less. The other question is whether PHDM can transmit infections. Whether by using another milk we can transmit a newer infection to the baby. It depends upon the quality of milk bank. The microbiology support that you are having, sticking to adhering to guidelines. Only babies who require it should be using it. No freelancing of all this milks to mothers who are at home or anywhere, or babies who don't require it. Careful handling of milk.
So the final question: what is the legality of using this to the newborns who are deprived of mother's milk?
It is so far legal. There are no any Indian codes which say whether to use it or not use it. But all the medical bodies, including American Academy of Pediatrics, even for term units, the PHDM is available, and the mother's milk is not available. We have made sure that it can't be there. Then you can provide it to the baby.
These questions are the benefit of the students.
Yes. Yes.
Thank you. Very nice.
Thank you.
So thank you, Suja. Next talk is going to be from Dr. Krishna Shankar on unraveling difficult diabetes mellitus, the challenges in type 2 diabetes.
So good morning everyone. So thanks for the opportunity. So every day, as individually I see, I believe I will gain experience. I'll be easy to handle diabetes. It's becoming difficult, more and more difficult every day for me. So it's becoming polymorphic, extensively complex network, type 2 diabetes, being influenced by so many factors that we'll discuss today. So this chart, if few of you may have seen, so this was a landmark study, UKPDS. You would have heard of the word UKPDS. So in the foundation of every disease, not just diabetes, every disease, if you hit very hard early, like in malignancies, cancers, if you hit very hard early in the phase, so the patient stands here on diagnosis. As time passes, the initial first 5 to 10 years, they won't be having any complications, no issues at all, no problem for the doctor as well as the patient. So, but that is a golden period. So what happens in India usually is we miss this golden period. So if you hit hard in the first 10 years of life, 5 to 10 years of life, So most of them, as a hospital, we won't be seeing this cohort at all. So whomsoever land due to diabetes complications, be it a stroke, be it a MI, be it a diabetic foot ulcer, be it a pyelonephritis, be it a pneumonia, whatever it may be, ARDS due to diabetes leading to an infection. So whatever it may be, whomsoever we see in our hospital tertiary center are all those individuals who have missed the golden period, the initial 5 to 10 years of diabetes mellitus. It also applies good whenever you diagnose in the tertiary center, then again start treating, consider those patients as a newcomers. So again, don't miss the golden period. So what is being emphasized here is maintenance of HbA1c, not just glucose control on that day alone when the patient gets admitted for a stroke, for a diabetic foot ulcer. Thereafter should maintain throughout life. So then you are going to avoid further complications. So because diabetes mellitus is not a single day entity, not lowering the glucose on that day. On that day you reduce 250, less than 180, the sugar is good. No. So all those complications occur on a single day, but the foundation, the microvascular damage has been going on for 10 years, which was preventable. So what is the treatment for diabetes? The entire diabetology, field of diabetology is included in this slide. Management of diabetes, that's all. This is my whole field of endocrinology for 3 years. The diet lifestyle, it is actually very complex and overemphasized because it's not easy. So if you consider today's, we had almost like 100 people had breakfast today. So but nobody had the same amount. Nobody has calculated BMI for them, their work today, how much they are going to work mechanically or just sitting. My field is just sitting in the bench. Surgeons do not calculate their BMI and effect output today. So even if physicians, example say ICU controls and other doctors do heavy lot of rounds, they didn't calculate BMI nor energy level, and accordingly they didn't calculate their protein. The server was asking, it is high glycemic food, good food, whether shall I take it or not. So all these are very, very complex. It's not easy for a food-based country. We love food, that too South India, that too Tamil Nadu, that too Coimbatore. Almost we peak in the different varieties of food. It's very, very complex, very easy to say to the patient. It's very even difficult to follow for ourselves itself. So it's almost literally overemphasized. We can just advise, and it's up to the patient's hands. We can keep on advising them, but only for the initial 5 to 10%. So thereafter, drugs take over. Definitely, drugs are ultimately important. It's being overemphasized in social media about that's for primary prevention, initial phases only. So drugs, major 4 drugs, that's all. Sulfonylureas, limiprid, glycoside, etc. Then gliptins, vildagliptin, sitagliptin, linagliptin, SGLT inhibitors. So empagliflozin, dapagliflozin, remogliflozin. I hope physicians, nephrologists and cardiologists will be using literally SGLT inhibitors nowadays a lot. Metformin, most of them use in every field, metformin. Pioglitazone, very, very rare. I use, very rarely used nowadays. Then GLP analogs. So these are the newcomers for the past 5 years, making a lot of noise. You would have heard about it in abroad, in North America and Europe, about Ozempic, weight loss drug, etc. So you won't believe it's still in vogue in India. It's there in our department. Almost we are using 1 to 2 patients per day. The thing is, the cost is very, very high, but they are excellent drugs. They are very excellent drugs. They are injectable format also, because due to loss of patency, we are being able to use it at a lesser cost in India nowadays. This is grossly underused. Then of course insulin, the wonder drug. So this is insulin awareness week actually, diabetes awareness week. That is predominantly due to it's a birthday of the discoverer of insulin, human insulin. So even before that, insulin was used. Banting and West developed for humans. So this week, 1 or 2 years back, in 1922. So that's why we are endorsing this week as diabetes awareness week. So remember this golden word: any glucose can be brought to normal. 100% it can be done, but not in just one day. Throughout the life, we have to maintain. It's very complex, but we can do it. It can be maintained, and whatever complications have occurred, has occurred. At least we can prevent further complications or prevent further severity. So why this confident statement? Simply because of this wonderful molecule. It's a Nobel Prize winning molecule, the lifesaver So before 1922, imagine for hundreds and thousands of years, all mammals had diabetes mellitus. It's not just a modern day phenomenon, we didn't document, that's all. All mammals, there is ample evidence of diabetes and its damages in teeth everywhere throughout the globe. All mammals have diabetes mellitus. Cow, dog. Still now the commonest cause of death in dogs is diabetes. They treat for diabetes for dogs. So for insulin, sky is the limit. There is no, it's the only drug where potency keeps on escalating. You escalate the level, the potency keeps on escalating. So yesterday we had a patient, we used 320 units per day. So there is no limit, upper limit for insulin. We keep on escalating particularly for individuals with pregnancy. So I used to get a lot of calls from the department of OBG. This high dose of insulin, what are you going to do? A very high dose of insulin. Of course, it will cause macrosomia and obesity, but no other. Bring down the HbA1c, bring down the complications. We have used 300 units, 350 units per day for individuals with pregnancy. Even without pregnancy, also we have used. So sky is the limit. Definitely, any amount of glucose can be brought down. So challenges in hospital. So extremely complex communication between glucose levels amongst the staff, amongst the doctors, between the doctor and the staff, between the staff. So very complex. None to blame because it keeps on varying. Lots of issues between the patients' family members. So if you wonder, the very reason the patient is admitted is for a complication of diabetes. You wonder, most of them, at least at a point of time, some 30 to 40% individuals will be admitted due to complications of diabetes. But the priority will be as the last. The treatment of diabetes and long term will be the last. So it is very common. Slowly we are bringing awareness about that. So the other challenges, nil per oral. Again, this is an extremely high Department of Medical Gastroenterology. They put on for endoscopies. So ICU patients, most of them nil per oral. Patient whenever aspirating. Neurology, many of them are on nil per oral or minimal feeding, aspiration in the first 24 hours. Suddenly it happens without caught unaware. After 3 days, they develop aspiration, they develop a pneumonia. Patient will be on again nil per oral, which will not be communicated to the physician treating the diabetes. So they might be getting drugs which will lead to hypoglycemia, erratic glycemic control. Again, vice versa. The sugars will be very high. Patient will be on a nil per oral, and it will be taken for granted if they are on nil per oral, don't give insulin. Again, this is very common, none to blame. So conventional human thought, no, it's not easy, it's not so straight. Again, liver, renal, infection, gut issues, everything will influence diabetes mellitus. Patient will go for hyperglycemia, on one day hyperglycemia, next day hyperglycemia, 24 hours it keeps on varying. So that's why we insist on initial first 3 to 5 days, frequent glucose monitoring. So barely some 400 rupees extra, 600 rupees extra, it is a lifesaver, frequent glucose monitoring in the initial 3 to 5 days. So renal dysfunction, very common. Most of them develop acute kidney injury, at least even trivial, 1.4, 1.5, 1.6 will change the insulin resistance, insulin levels, will change almost everything, go for hypoglycemia, again hyperglycemia. So infection, again it varies. So gut issues, most of them will develop some gut issues, nausea, vomiting, need not be a primary gastrointestinal pathology, they will be having a pneumonia, they will be unable to feed, develop ulcers. So patient will be, many a times you have seen metformin will be continued. Metformin is a notorious agent for the gastrointestinal tract. So any issue in the gastrointestinal tract, stop metformin. So we will go and stop it because it will be exaggerating. Patient will be treating for a different issue. So that issue will not get solved. So hypoglycemia, most important, fear of hypoglycemia in hospital. Not just hypoglycemia, fear of hypoglycemia. So insulin will not be given. Of course, anyone can develop hypoglycemia with insulin or tablets. Anybody, any individual person. But we cannot refrain from treating the patient. We have to treat. So does NPO, another $1 million question from the staff predominantly, does NPO always require stopping drugs or insulin? So not at all. There is no hard and fast rule. There is no given evidence that we should stop. Of course, we cannot give drugs for NPO logically. So even Amit said we have given it, but again it is not hard and fast because we give thyroxine. We give thyroxine, even the patient is on nil per oral, we give thyroxine to make them fit for the surgery. Insulin, definitely we have to do. What if the sugars are more than 300? 450, what to do? So from anesthesia we get a blanket rule, nil per oral on day of surgery. Good. So what if the sugars are 450 on the day of surgery? Can we do the surgery or not? Of course you can proceed with the surgery. Of course, if it's a life-threatening surgery, obviously we have to do. Of course, you have to do endoscopy, a bronchoscopy or gastrointestinal endoscopy. We have to proceed. Even biopsy, we have to proceed. They have come all the way. We cannot keep on waiting for glucose to come down. Why? Glucose is a dynamic phenomenon. If you check the average glucose of all of us now, so forget individuals with diabetes mellitus. All of us now, definitely none of them will be alive. None of them will be alive. Keep on varying. So it's a dynamic phenomenon like life. So there is no hard and fast rule. Again, on day of surgery, if the morning sugar is more than 400 or day of endoscopy, do we need to postpone the surgery? Not at all, but we need a plan. HbA1c 13.5. Patient has come for a huge abscess. You want to drain the abscess from the liver or do a amputation, a foot ulcer. You want to proceed. Definitely we can do. Increase the frequency of checkups. Put on a sliding scale infusion or a subcutaneous infusion. Increase the frequency of checkups. Then proceed for surgery. There is no contraindication. You have to be aware. And subsequent glucose control should be meticulous and long-term plan. Again, long-term plan. So glucose, it's a dynamic phenomenon, keeps on varying. So it all depends, the control and the fitness, everything depends on previous duration. How long the patient was on high glucose level. For 13 years, 33 years, we have patients for 43 years, 33 years, 25 years, every day we see. So 13 years, just 2 years, just 1 year, newly detected diabetes. Very, very easy to control, very extremely easy to control. There's a huge difference between 400 sugars between an individual with 1 year of diabetes and 10 years of diabetes. It is not the same. For an individual with 10 years of diabetes, 23 years of diabetes, with a bypass surgery, with a MI, coming with a heart failure, coming with a kidney disease, we go very, very, very slowly. So people think we have to bring down the glucose surgery. There is no hard and fast rule. They would have developed autonomic neuropathy. They will go for hypoglycemia. They will go for cardiac arrest. Or they will have very, very poor quality of life. Lot of diaphoresis, lot of excessive sweating. So hypoglycemia, unawareness, so many things are there. Neuropathy will be there. Every fall they will get a fracture with hypoglycemia. So for individuals with 23 years of diabetes, already with retinopathy, already with nephropathy, we go very, very slow for them. Bring slowly the glucose in a month to less than 150, 160. So although long-term HbA1c matters, not just today's HbA1c, we have to maintain it throughout life to prevent further complications. So although complications are acute, we might wonder, so only today he got tuberculosis, only today he got a stroke, he got gallbladder emphysematous cholecystitis, today he got, no. For that the foundation has been going on for 5 to 10 years. Microangiopathy is slowly occluding for 5 to 10 years, and when it goes beyond the critical occlusion, then they develop a MI, then they develop a stroke, then they develop a retinopathy, a foot ulcer. So only then they develop. The moment they have foot ulcer, we diagnose the individuals having uncontrolled diabetes for almost minimum of 5 years. You can guarantee say it's minimum of 5 years. So not today's HbA1c, not today's glucose doesn't matter. So we have to of course bring it down. Need not panic on that 400, 500 for seeing the patient on that day. So reduce gradually over days. Of course for inpatients, plan long-term treatment in the hospital itself. It's a very, very complex country, we all know. We don't know, nobody of us know the patient will come back or not. So for my patients, I don't emphasize too much, please come back immediately. I just tell them, because my patients, I don't know whether they will come back or not, they will survive or not, I don't know. I don't emphasize too much. But if they come, it's good for them. So we need long-term plan in the hospital itself. So if I think, okay, I'll give a plan later, so they don't turn around. Many times, multiple reasons are there, they don't turn around. So I try to formulate a long-term plan. Whenever in the ward itself, it's an opportunity for me as an endocrinologist, an opportunity, the 5 days or 7 days in the ward, to make a plan. Sometimes it may appear atypical. When we are formulating a plan, I ask the patient, how was your treatment previously, 1 year back? So do you have GI side effects with metformin? Did you develop hypoglycemias? Were you giving injection correctly? So we need a separate class for the whole staff and frequent classes for insulin techniques, not just for them to know, to pass on to the patient. We also need a diabetes educator to pass on to the patient and again recheck whether they have done it correctly or not. So all these matters. So scenarios of diabetes. So newly diagnosed, these are the 4 scenarios we see, diabetes mellitus. Newly diagnosed, going on. Diabetes being diagnosed, treatment is going on, but uncontrolled, one scenario is controlled. So admitted for complications. Until now, no complications, and a new set arrives, admitted for complications. This is a new set. And moribund. Extremes of age, extremes of complications. Creatinine of 4, severely sick patient, oncology patient, a patient has got multiple comorbidities, palliative care, age of 93, we go very slow, very slow for them because there is no benefit, extra benefit for perfect glucose control. It causes burden for them. Check the glucose frequently, you have to give insulin frequently. So what is the point? Ultimately we are treating to allay the pain and suffering, not to too much burden on them. We need evidence. So all these, they belong to category C, we have to bring down slowly without undue burden on their life. So this is a few cases in the hospital. Interesting case, proximal myopathy, middle-aged lady with diabetes, HbA1c of 12.1. Again, we see a lot of patients with myopathy, apart from the routine conventional cardiac issues, renal issues and foot ulcers, other issues like very poor quality of life, memory loss, insomnia, they lose a lot of muscle, very poor immunity, recurrent infections. Other things won't be there, they won't develop a cardiac failure or a kidney failure, but recurrent infections, respiratory tract infection, urinary tract infection, recurrent infections, even at low HbA1c of 9 itself. Those kind of individuals require meticulous control. All their problems vanish. This individual proximal myopathy, they were on 30/70 insulin of 1208 and metformin. So we just changed to basal bolus insulin. Not great glucose control, even changing the model of insulin, and we took out the metformin, the truncal power improved for them. Quality of life improved. So this 70-year-old lady referred for type 2 diabetes, HbA1c of 8.3, blood pressure of 180, 110, pedal edema, back pain, proximal myopathy, hypokalemia and alkalosis. Sugars were 500, requiring tons of insulin, lots of insulin, and cortisol was 45. So incidentally, we found that a Cushing syndrome in this individual. So what I'm trying to say is, it's not about Cushing syndrome, it's not a discussion about Cushing syndrome. So how they are present. So many of them not straightforward type 2 diabetes mellitus, sort of 100, 90 will be like that. Other 10 will be having Cushing syndrome. Obstructive sleep apnea, obesity will be a resistant factor to uncontrolled diabetes mellitus. So we have to think other disorders also, not just diabetes. Many will be hidden for Cushing syndrome, for acromegaly, for OSA, common obesity and obstructive sleep apnea. So 11-year-old, so this is a classical type 1 diabetes, nothing new in it, just to show I'm saying. Osmotic symptoms 543, sugars, HbA1c of 13. So we started the infusion requiring 80 units per day initially. Then finally, eventually we need just 20 units per day. So this usually occurs. Initially we need lots of insulin, lot of therapies. Subsequent, after control, the resistance comes down. We need only lesser amount of insulin and lesser OADs in type 2 diabetes. So this is another common scenario case. It's a creatinine of 2, kidney injury, albumin, urinacia 1000, hypertension, multiple OADs with purpura, bone vasculitis, MCTD, etc. So this case was diagnosed with DKD with non-diabetic kidney disease. Patient started on steroids. So why I emphasize this page? Multiple departments use glucocorticoids. I don't think there is any one department just not use glucocorticoids. Of course, I think surgeons don't use it, but most of the departments use, medical departments, they use glucocorticoids. Of course, they are lifesavers, be it oncology, nephrology, pulmonology, lot of disorders, immunology, of course, immunology and rheumatology, dermatology, many disorders they use steroids. So, definitely they are against, obvious, they are against insulin. So, this lady was on 40 milligram of isolone. You have to reduce the glucose, that also protects the kidney. You have to do that part also, but you cannot take out steroids. Only the treating physician has the discretion to decide upon that. So this patient needs meticulous treatment. It's not easy. We have to go So when putting on steroids, particularly when you're putting on steroids, they have a peculiar character. What happens is due to feedback, they get early morning hypoglycemia and very delayed hyperglycemia. Because we change the feedback. We change the feedback of cortisol. So what happens is early morning hypoglycemia and lunch, dinner, night hyperglycemias. So see this requirement of insulin for the patient per day almost 100 units, large in insulin, long acting, and short acting say 36, 48 units in the lunch and 70 units in the night. So we are literally using almost 100 to 200 units per day. We get at least 5 to 10 patients per week like this. So HbA1c came down to 8. Eventually came down to 8. Look at the insulin resistance steroids cause. And creatinine has come down. So stroke, diabetes, another new individual on OADs. The stroke is improving. Riles tube was removed since the patient had aspiration, but still hiccups and nausea present. People are wondering what is the reason patient has improved. But the patient was on metformin and gliptins, simple agents commonly used oral antidiabetic therapies for diabetes mellitus. We just stopped the metformin and gliptins, that's all, it vanished. Hiccups vanished. We had patients in medical gastroenterology where severe constipation, eventually it was attributed to sitagliptin, simple commonly used OAD. So this individual, again, nowadays more and more cardiologists have started using SGLT inhibitors in the field of, we need heart, they're excellent drugs, very well established, again in nephrology also, very well established as cardioprotective and renal protective, also for obesity also. So this individual was optimized SGLT 7.9 on OADs. From cardiology, dapagliflozin was started. For heart failure, of course they are the guidelines, but went to severe hypoglycemia because it's also an oral antidiabetic agent. Patient developed heart failure because of the hypoglycemia. So dose reduction was done of other OADs. Other drugs, the dose reduction was done. So one case, the calculation of this. So 50-year-old, 20 years of diabetes, hypothyroidism, non-healing foot ulcers, multiple surgeries, very, very common scenario across the nation. It's a commonest scenario across the nation. Non-healing foot ulcers, multiple surgeries, they keep on roaming around the surgery department. So 4 OADs plus insulins, Lantus of 50 units, Atrapid of 40-20. Look at the amount of insulin they require. It's not rare, we use it. The problem is poor follow-up with endocrinology, but gets treated for other issues. They think, okay, we'll treat this has to come down. They forget about diabetes, that diabetes is the cause for their foot ulcer. So unresolving foot ulcer develops a heart failure also. So comes after 8 months, HbA1c was 11. So I discussed about a drug called GLP-1 analog. So I just started that drug. The moment I started that drug, everything came down. Patients started developing hypoglycemia. See, if required only low dose of insulin, the foot ulcer is healing, the patient has started losing weight. So what I emphasize here is, if the patient had come 6 to 7 months back itself, we would have done this work. So all this would have been resolved. So it's a very complex, all these challenges in India, we need lot of introspect, lots of counseling, again communication. So diverse population culture, both doctors and patients, difficulty in adherence to guidelines, inertia to customize. We have to customize, keeping on customizing. In patients, we keep on changing daily. We have to customize according to their feeding, their comorbidities, whether going for endoscopy or surgery, head injury. Suddenly the patient may be not there, will be in ICU for something else. We have to again, we rush, we run there, we stop the drugs, we change the drugs again. So a lot of things has to be done. So tendency to keep the note. We should not keep, we try to customize every time diabetes, every 3 months we try to customize what are the side effects, what new has come, and easier rather to learn and tougher solutions, because the problems will be much larger. This will be much easier. So denial of complications in pregnancy, just a single side about pregnancy. So need not push for OGTT in unequivocal cases. It's crystal clear, about 200 sugars in induced pregnancy. Think it is diabetes. Think of the worst part. Don't again push for OGTT. So most important what we see is in individuals who are delivered with gestational diabetes. Thing is, your diabetes is resolved. It's okay, happily go and come. No. 30 to 40% of them will develop type 2 diabetes in the future. Remember, type 2 diabetes is not preventable. Type 1 diabetes is not preventable. Only type 3 certain forms are preventable, like drug-induced diabetes, etc. Type 2 diabetes is not preventable. You can postpone pharmacotherapy. It is not preventable. So they need follow-up. So follow-up testing is a must, and individuals with pancreatitis, Again, individual pancreatitis need meticulous follow-up. Any time, any point of their life, they are prone to develop diabetes mellitus. Actually, it's type 3 pancreatic diabetes mellitus. Again, it cannot be prevented. So, thank you for your short question.
Thank you, Krishna. So complex requires communication and requires meticulous follow and forever itself. So any questions?
Gold standard for diagnosing diabetes because the individual might come with an blood transfusion or blood loss, so the HbA1c level varies for those individuals. So is that true or?
That's why we do glucose. Obviously, we do for diagnosing. We do a glucose. That's all. Once you have a doubt, patient is transfused. HbA1c is 9. You have doubts whether the patient has got diabetes or not. We diagnose diabetes with HbA1c, but we don't treat incidentally with HbA1c. We see the glucose level, then only we start treating. Your point is well taken. Patient has got anemia, you are bleeding, you are transfused, pregnant lady. We don't just rely on HbA1c. Only for diagnosis we rely, but for treating we need glucose level. Only if the glucose goes beyond 200 and the fasting more than 150, we start treating with therapy, tablets. Else we don't jump to treatment. And again, follow up.
Thanks. I think his question is better to modify to postgraduate is what are the fallacies in the measurement of HbA1c? So there can be falsely high, there can be falsely low.
Yes.
So can you take
anemia? Commonest fallacy is anemia. Day to day in our hospital, basically almost all the departments are complete. We have all departments. So anemia is a universal disease everywhere. Anemia is the commonest fallacy. So don't trust HbA1c if the anemia is less than hemoglobin is less than 9. Blood transfusion, of course, don't trust the HbA1c. Acute bleed, don't trust the HbA1c. And dilution, sir, in heart. But actually, it's quite rare. But in anasarca, severe heart failure, anasarca, third space fluid accumulation, better not to trust the HbA1c. We have incident glucose, and these patients don't forget not to do HbA1c after 3 to 6 months. Of course, in hemoglobin studies, we can never trust the HbA1c. We won't do because the machine will not detect it.
So, any more questions?
Depends on how long they were having. In type 2 diabetes, usually at the diagnosis, mild vasculopathy would have started. So we have seen patients straight away with the foot ulcer. Diagnosis of diabetes with the foot ulcer. Diagnosis of diabetes with the heart attack. The heart attack will be diagnosed. That's even more common. We diagnose heart attack. Now only they have discovered diabetes mellitus in that individual. So they will be shocking. How come it came? They will be thinking it came because of the heart attack. Came because of the kidney failure they got diabetes. No, not at all. Because of the diabetes they got all these things.
So there are no more, sir, you have something.
Is it necessary to treat? Is it necessary to treat pre-diabetic? You told us, anyhow they are going to be diabetic. We are only postponing the
pharmacotherapy, sir. Yes. Sir, no need to treat. If you start treating, it becomes diabetes. So I usually depends, sir. I usually don't start on metformin, whatever. I put them on diet only, sir. But I emphasize them. This is diabetes. You don't need medicine now. And usually no need to treat, sir. But definitely lifestyle. Of course, lifestyle modification, weight loss to adequate BMI, and check up every 3 months.
Is it possible to reverse pre-diabetic by avoiding grains?
Sir, to reduce the carbs and change it. We cannot avoid, sir, we can postpone. For eternity, it depends on the genetic predisposition of that individual. We can postpone, sir, but not for all. It's not a single plate for all, sir. For each and every individual varies. More the obese, there's one paradox I like to quote. It's better to have type 2 diabetes with obesity rather than be lean with type 2 diabetes. Because you have an option of weight loss also rather than therapy drugs, but if you are lean, you don't have that option. So that is actually a positive one about obesity. If you have obesity, you have an option of doing just lifestyle modification and weight loss then go for pharmacotherapy.
Okay.
So, a single line. Why the pioglitazone came in a big way and not intervalist liking now?
We are the only person who use. Pioglitazone, what happened was initially.
As against, 10 years ago.
Yes, sir. 2007, a very good guy called Steve Neeson. He's a wonderful researcher. He was brought about that individuals with pioglitazone developed heart failure. Statistically, they proved. Then they banned the drug pioglitazone. Now, after again time-based studies, they have found out doesn't cause heart failure. It's a class effect of edema, fetal edema. Again, they have brought back pioglitazone, sir. So we have started using pioglitazone, but we don't use in individuals with edema or heart failure. We don't use it.
So, we should count the number of black grams in the plate as you counted in the morning. So that's
We discussed, sir.
So thank you all, and thank you. We will meet in the next clip.
Thank you, sir.